Ever tap your cheekbone and thought about what's really underneath? It's
Right.
more than just, how you look. It's a structural linchpin of your face, the powerful zygoma.
Absolutely.
Today we're taking a deep dive into what happens when this crucial bone, well, because it sticks out, it takes a hit.
Yeah, it's right out there.
We're talking about zygomatic complex fractures, or ZMC fractures for short.
Right.
And this bone isn't just floating there, is it? It's intricately connected to 4 other major bones.
That's right. Your frontal bone, sphenoid, temporal, and maxillary bones. It really forms a key part of your mid-face strength.
Okay.
And this is where, our understanding has really changed over time.
How so?
Well, for decades, these breaks were often called tremolar or tripod fractures. You might still hear those terms sometimes.
Tripod. Yeah, I've heard that.
But with modern imaging, especially CT scans, we realized those terms were actually, well, pretty misleading.
Misleading?
They missed a crucial part of the injury, specifically the connection to the clinoid bone, deep in the orbit, the eye socket.
Ah, okay.
So now we know a true ZMC fracture is far more comprehensive. It
Yeah.
affects a whole complex of structures, not just 3 points. Those older labels just didn't capture it all.
That shift in understanding, that's exactly what we're here to explore today.
Mm-hmm.
Our mission, really, is to give you a comprehensive but, totally digestible understanding of these intricate facial fractures.
Yeah, break it down.
We'll journey from how they happen through the meticulous processes of diagnosis and treatment, and even look at the potential complexities that can pop up.
It's quite a journey.
Think of this as your shortcut to understanding a critical, often overlooked aspect of facial trauma.
Let's do it.
So let's start with the star of our show, the zygoma itself. How would you describe its fundamental shape and its key connection points? What makes it so central?
Well, it's a marvel of engineering, really. If you imagine a sturdy quadrangular bone, sort of like a 4-sided keystone.
Okay, 4-sided.
It has 4 main projections reaching out. One goes up towards the forehead, one back towards the temple, one down towards the upper jaw, and one forms part of the lower rim of your eye socket. So it's not just a single bone, it's like a central hub.
A hub. I like that.
And for us to classify a fracture as a ZMC, all 4 of its major connections, we call them articulations, must be disrupted.
All 4.
All 4. That includes where it meets the frontal, temporal, maxillary, and that deeper sphenoid bone. And here's a critical point, one that's often misunderstood.
What's that?
All true zygomatic complex fractures involve the orbital floor, the floor of the eye socket.
So if the cheekbone breaks, it's almost guaranteed the eye socket is involved too.
Exactly. Which is why anyone dealing with these injuries needs a really deep understanding of orbital anatomy.
Makes sense.
Think of the orbit, the eye socket, like a sturdy 4-sided pyramid lying on its side.
Yeah.
The floor of that pyramid is surprisingly delicate, actually, and it's the shortest of the orbital walls, only about 47 millimeters, roughly 1.5 inches long.
Wow, that's small.
Yeah, and it's made up of 3 different bones. The maxilla, the zygoma itself contributes, and a small bit of the palatine bone, too.
But the story of the cheekbone isn't just about hard bone, right? It's tangled up with nerves and muscles, too. What kind of sensory impact can a ZMC fracture have?
Oh, a significant one. The second division of your trigeminal nerve, that's the main sensory nerve for this whole region.
Trigeminal, yeah.
It branches out, you see, providing sensation to your cheek, the front part of your temple, the side of your nose, your upper lip, and even your upper teeth.
So a fracture could mess with all of that.
Easily. It can disrupt those branches, leading to numbness or that pins and needles feeling, tingling.
And muscles.
Yeah, beyond sensation, you've got muscles like the zygomaticus major that helps you smile, and the masseter, which is crucial for chewing. They attach here.
Right.
Their function can definitely be compromised if the bone supporting them is shifted or damaged.
And what about the soft tissues, the things holding everything in place, especially around the eye?
Absolutely vital. You've got Lockwood's suspensory ligament, which kind of cradles the eyeball, helps support it.
Okay.
And the Canthal tendons, which anchor the corners of your eyelids.
Right, the corners.
So when the zygoma gets displaced, pushed down, or out of place, we often see a clinical sign called an anti-mongoloid cant.
Anti-mongoloid cant. What does that look like?
It's a telltale downward slant of the outer corner of the eye. It tells you the cheekbone has shifted downwards. It's a clear visual cue to a deeper structural problem.
Okay, fascinating. So we've kind of dissected the cheekbone's engineering, but how does such a, well, seemingly robust structure actually break? What causes these ZMC fractures? You mentioned demographics and geography, play a role?
Yeah, it's really interesting how our environment shapes the injuries we see. It really makes you think.
How so? Give me an example.
Okay, so take a study by Matsunaga and coworkers in Los Angeles. They looked at over 1,200 zygomatic fractures,
Wow.
and they found the clear majority, were from motor vehicle accidents, MVAs.
Okay. LA, cars, makes sense.
Right. But now contrast that with a study by Ellis or colleagues way over in Glasgow, Scotland.
Oh, yeah, different place.
Totally different picture. There, a staggering 0% of these fractures were caused by assaults, falls, or sports injuries.
80%. That's huge.
Yeah, and only about 13% were from MVAs.
That's a really stark difference. What drives that? Is it like socioeconomic factors or cultural things?
It probably points to a whole mix of things, doesn't it?
Yeah.
Public health issues, maybe urban design, like how much people drive versus walk, the popularity of contact sports, maybe even rates of interpersonal violence. It just highlights that medical challenges like these, they're rarely just medical. They're tied into broader societal factors.
Okay, so once an injury happens, diagnosis is obviously key. You mentioned these aren't usually immediately life-threatening.
Generally, no. Which is actually helpful in some ways. It often means doctors can wait a few days, typically 4 or 5. Well, it lets the initial swelling go down, which makes assessing the actual bony injury clearer, and it gives time to stabilize any more serious injuries the patient might have alongside the facial fracture.
First things first.
Right, stabilize the patient. So what does that initial evaluation involve?
It's incredibly thorough. You're looking beyond just the broken bone. We meticulously check the surrounding soft tissues, eyelids, tear ducts, those Cantal tendons we mentioned, and especially the eyeball itself, the globe.
Okay.
And we test crucial cranial nerves, particularly 2 through 6, which relate to vision, eye movement, and facial sensation.
2 through 6.
And here's a non-negotiable rule. Any suspected eye injury, even if it seems minor, always requires an ophthalmologist consult. An eye specialist.
Always.
Always. They need to check visual acuity, pupillary response, the position of the globe. Their expertise is paramount. You just don't take chances with vision.
Absolutely. And from the patient side, what are they likely feeling or reporting? Well, pain, obviously. And you'll see swelling and bruising around the eye. We call that periorbital edema and ecchymosis.
Right, the classic black eye look, but worse.
Pretty much, yeah. That's present in over 60% of these injuries. And then there's the numbness or tingling paresthesia.
Ah, the nerve thing.
Exactly. A significant number. It varies a lot in studies, but anywhere from maybe 18% to over 80% of patients experience that across their cheek, upper lip, maybe even upper teeth.
That sounds really uncomfortable.
It is. They might also have difficulty opening their mouth fully. That's called trismus. Sometimes nosebleeds, or even double vision, which we call diplopia.
So when you, as the doctor, do a physical exam, what are you specifically looking for? What are you feeling for?
We're essentially trying to map the displacement, figure out where the bone has moved. We palpate, gently feel for a flattening of the cheek prominence, the malar eminence.
Feeling for a dip.
Yeah, exactly. Has it sunken in? We'll look for that anti-mongoloid slant of the eye corner we talked about.
The downward slant.
Right. And often there's bleeding under the surface of the eye. The white part, that's a subconjunctival hemorrhage. Looks dramatic, but it's common.
Okay.
Critically, we palpate the entire orbital rim, all 360 degrees around the eye socket, feeling for any tenderness or maybe a little step off where the bone fragments aren't lined up right.
A step off, like a little ledge.
Precisely. And we also check jaw movement carefully, make sure the broken zygoma isn't blocking the lower jaw, the mandible, from moving properly.
You mentioned eye injuries earlier.
Yeah.
The stats on those seem pretty serious. It's really not just about the cheekbone, is it?
Oh, far from it. It's a major concern. Studies like one by Barry and Associates, they looked at 138 patients with ZMC fractures and found 23 of them, that's a significant chunk, had associated ocular injuries. Things like double vision, the eye sinking back, which is anophthalmos, or even retinal tears and hyphema, which is bleeding inside the front part of the eye. And another study, Jamal and coworkers, they categorized injuries in almost 100 patients. They found that while many had relatively minor things like that subconjunctival hemorrhage.
So bleeding on the white part?
Yeah. But a full 10% suffered major ocular injuries, including ruptured globes.
Ruptured globes? That sounds awful.
It is. It's a devastating injury, and it absolutely underscores why you need that immediate eye specialist consult for anyone with these types of facial fractures, no exceptions.
Definitely hammered that point home. Okay, so after the initial assessment, the physical exam, how do doctors get the definitive picture? What does this all mean for actually seeing the bone breaks?
Right, the imaging. Well, back in the day, plain x-rays were the main tool. Things like the Waters view, that was often called the single best x-ray for ZMC fractures.
Well, Waters view. Yeah.
But medicine moves on, technology improves. Today, CT scans are unequivocally the gold standard, no question.
CT scans.
Yeah, taken in both axial, that's like looking down slice by slice, and coronal planes looking from the front, they provide an incredible level of detail.
What kind of detail?
You see the exact fracture patterns, how far the pieces have moved, the displacement. You can see if the bone is broken into multiple small fragments, that's comminution.
Combination, right.
And critically, CT lets us thoroughly evaluate the soft tissues around the eye, check for muscle entrapment, things like that. Those coronal views, looking from the front, they're particularly invaluable for seeing the midfacial buttresses, the strong points, and those critical orbital floor fractures.
So it's a complete game changer compared to old x-rays.
Absolutely. Lets you understand the full extent of the injury before you even think about treatment options.
Okay, so with all that amazing detail from the CT, doctors can then classify these fractures. You mentioned this has shifted from older systems based on x-rays to these newer CT-based ones. What's the main goal of classifying them now?
Yeah, the classification systems have evolved quite a bit. The core idea really behind the modern CT-based systems is to help guide treatment.
Guide treatment for now.
They're essentially trying to predict which fractures are going to need more aggressive surgical approaches. They classify them based on the severity of displacement, how far the bone has moved, and comminution, how many pieces it's broken into.
So more broken up, more displaced means more surgery.
Generally, yes. For instance, Manson and colleagues back in 1990, they grouped them into low energy, middle energy, and high energy injuries.
Oh, middle, high.
Makes sense. Low energy meant little or no displacement. Middle energy meant a complete fracture of all those connections with mild to moderate displacement. High energy meant lots of comminution, significant displacement, maybe the arch breaking into segments.
Okay. Any other systems?
Yeah. Another well-known one is from Zing and coworkers in 1992. They used types A, B, and C.
A, B, C.
Type A was incomplete, maybe just one pillar broken. Type B was a complete fracture through all four connections, but the zygoma itself was basically in one piece, a monofragment.
Got it.
And type C was where the zygoma itself was broken into multiple pieces, a multi-fragment fracture.
So if we step back and connect the dots, the more significant the displacement and the fragmentation, the more likely you're looking at serious surgery.
Precisely. That's the common thread running through these modern classifications. As the amount of bone breakage and displacement increases, so does the need for open reduction and internal fixation.
Open reduction, internal fixation, ORIFs.
Exactly. Surgery to directly expose the fractures, put the bones back in the right place, that's the reduction, and then fix them there. Usually with small plates and screws, that's the internal fixation.
Right. So once you have that clear picture, the diagnosis, the classification, how do you actually treat it? It sounds like it's very tailored to the individual.
It absolutely is. There's no one-size-fits-all. Treatment really ranges from just simple observation for very minor, non-displaced cases.
Just watch and wait.
Yeah, sometimes if it's barely moved and not causing problems, watchful waiting is appropriate. But it can go all the way up to complex surgical intervention for the really severe fractures.
Okay. What about just the arch? If only that part below the temple is broken.
Right, isolated zygomatic arch fractures. If it's not displaced, not pushed in, surgery might not be needed at all.
But if it is pushed in, what then?
Well, historically, some interesting methods were tried. Things involving sticking fingers in the mouth to push it out.
Seriously?
Yeah, less precise, obviously. But the real game changer came way back in 1927 with the Gillies technique.
Gillies, 1927. What's that?
It involves making a small incision, usually hidden up in the hairline in the temple region.
Ah, hidden scar.
Exactly. Then you slide a special elevator instrument underneath the temporalis fascia down deep to the arch, and you gently lift the depressed fragments back into place.
Clever.
It is. And that approach, or variations of it, is still a cornerstone for treating depressed arch fractures today.
Ugh.
And interestingly, for isolated arch fractures, once you pop it back into place, fixation like plates and screws is actually seldom needed. It tends to stay put.
Okay, so that's the arch. What about the full ZMC fractures, the complex ones?
Right. So the low energy ones, minimal displacement, again, might just need observation, though you watch them closely in case they shift later.
Okay.
But middle energy fractures, Those almost always require surgery or RF to realign and fix the bone properly.
Plates and screws time.
Pretty much. And since the 1990s, there's been a definite shift towards using these tiny miniplates and microplates for fixation. They're strong but low profile.
And how do they get the bone back in place first?
There are different techniques. An approach developed by Ellis and Kitty Curring might use a special screw, like a Carroll Girard screw, inserted through the skin to grab the main fragment and pull it into position.
Like a handle.
Kinda, yeah. If that reduction isn't stable on its own, then they'll proceed to open surgery, making incisions to expose the key buttresses, often the zygomaticomaxillary, down by the upper jaw, and the zygomaticofrontal, up near the eyebrow, and apply plates there.
Okay, and the high-energy ones, the really smashed-up ones.
Those demand the most aggressive approach. Because you've got significant comminution, the bone is in many pieces, the arch might be in segments. It's complex. These often require orbital floor reconstruction as well.
Big surgery, that.
Yes. Access typically involves a coronal flap that's an incision across the scalp from ear to ear, hidden in the hair,
Wow.
to get wide access to the arch and the top of the zygoma. And then the smaller incisions near or inside the eyelid, like transconjunctival, to access the orbital rim and floor.
Given how complex these can be, all those connections,
Yeah.
how systematic is the surgery? Is there like a standard order for fixing things?
That's a great question. While every case needs individual judgment, yes, there is generally a systematic approach, especially in the complex, high-energy injuries. It helps ensure you restore the proper facial height, width, and projection accurately.
So what's the typical sequence?
Often, in those high-energy cases, surgeons will stabilize the zygomatic arch first.
Why the arch first?
Because it reestablishes the correct width of the face, it acts like a scaffold. Once the width is set by fixing the arch, then they move to stabilize the anterior buttresses.
The front connections.
Right. The zygomaticofrontal up by the brow, the zygomaticomaxillary down by the jaw, and the infraorbital rim around the eye. Fixing these points locks everything into its proper 3D position. It's kind of like building the face back from the outside in, if that makes sense.
Yeah, it does. Building on that stable arch framework.
Exactly.
And how do they get to those specific spots? What kind of incisions?
Surgeons tailor the approach to the specific area they need to fix. For the zygomaticomaxillary buttress, down low, an incision inside the mouth in the upper gum line is often used.
So no visible scar.
Right, that's a huge plus. The soft tissue there is thick, so plates aren't usually palpable either.
Okay. What about higher up?
For the zygomaticofrontal buttress, near the outer eyebrow, small incisions can often be hidden right in the eyebrow itself, or sometimes in a natural eyelid crease, like the supratarsal fold. That gives great access to good, strong bone for fixation.
And the eye socket, rim, and floor.
For the infraorbital rim and the orbital floor, surgeons might choose transcutaneous approaches, meaning through the skin, like a subtarsal incision just below the eyelashes.
Below the lashes, okay.
Or, increasingly popular, are transconjunctival approaches. That's where the incision is made entirely inside the lower eyelid.
Inside, so definitely no visible scar.
Correct. It's cosmetically excellent, though any approach near the eyelid carries some risk of complications, like ectropion, where the eyelid pulls down, or scleral show, where you see too much white below the iris.
How do they prevent that?
There are techniques like careful dissection and something called periosteal resuspension, which basically means carefully stitching the eyelid tissues back up to the bone at the end to support them and prevent them from sagging.
Okay. And if the orbital floor itself needs fixing?
Right. If exploration is needed, maybe because the eye has sunk back and ophthalmos, or the patient has persistent double vision, or the CT clearly shows a big defect or trapped tissue.
Then you have to rebuild it.
Exactly. Reconstruction is vital. We can use various materials, sometimes autografts, meaning bone taken from the patient themselves, maybe from the skull or hip,
Okay.
or allografts, which is processed donor bone, or very commonly now, alloplastic implants synthetic materials like porous polyethylene or thin titanium mesh.
Titanium mesh, wow.
Yeah, it's strong and can be contoured precisely. Whatever material is used, it's carefully placed to bridge the defect, usually resting on an intact bony ledge at the back of the orbit, typically about 35-38 millimeter behind the rim.
Precision work.
Very much so. And before closing, it's critical to do forceduction tests.
Forceduction?
Yeah, the surgeon gently grasps the eye muscles with forceps and moves the eye around to make absolutely sure they're moving freely and aren't still entrapped by the fracture or the implant.
Makes sense. Check the movement.
Crucial step.
And for the really bad injuries where maybe some bone is just gone or too crushed to use, I assume bone grafting comes in.
Absolutely. In those severe comminuted fractures with actual bone loss, early bone grafting is often essential to restore the missing structure and support. You need to rebuild that scaffolding.
Okay. And after all that surgery, what's the post-op care like?
Postoperatively, patients usually receive antibiotics, especially if the maxillary sinus was breached by the fracture, to prevent infection. Sometimes decongestants are used too to help sinus drainage if it's involved, and then it's about managing pain, swelling, and starting gentle recovery.
Okay, it's clear this is complex stuff. But even with the best care, the best surgery, sometimes complications arise, right?
Unfortunately, yes. Even in the best hands, complications can happen. It's the nature of treating significant trauma.
What are some of the potential issues patients might face after a ZMC fracture? What makes them tricky?
Well, one of the most common is that infraorbital paresthesia, the numbness or tingling.
Right, the nerve issue again.
Exactly. Its incidence is really high, reported anywhere from 18% to over 80% of patients initially.
Does it get better?
It often does, but recovery time varies a lot. Maybe 4 weeks for non-displaced fractures, but potentially 13 weeks or longer for displaced ones. And sometimes, especially if the nerve was directly cut or badly bruised, the recovery can be incomplete. Some studies suggest early ORF might lead to better nerve function outcomes, though.
Okay, what else?
Malunion and asymmetry. That's when the bone heals in the wrong position.
So the face looks off.
Yeah, it can lead to a flattened cheek appearance, poor malar projection, or maybe the face looking too wide on one side. This often results from inadequate reduction, not getting the bones lined up perfectly during surgery.
Can that be fixed later?
It can, but late corrections are really challenging. They usually require complex osteotomies, re-breaking the bone, and often bone grafts. It's much better to get it right the first time. That's one reason intraoperative CT scanning during the initial surgery is becoming more common, to check the reduction accuracy right then and there.
Intra-op CT. Smart. Okay, what about the eye sinking back? Inophthalmos.
Ah, yes, ophthalmos. To understand why this happens, Grant and colleagues used a great analogy. Think of your eye socket not as a simple box, but more like a cone.
A cone. Okay.
Even a small fracture that slightly increases the radius, the width of that cone, can lead to a surprisingly dramatic increase in the total orbital volume.
Bigger cone, same size eyeball?
Exactly. So the eyeball sinks back to fill the larger space. Studies show that just a 13% increase in orbital volume can result in over 2 millimeters of an ophthalmos, which is definitely noticeable.
2 millimeters sounds small, but on a face.
It's very visible. And roughly speaking, every cubic centimeter of displaced tissue or increased volume can equal about a millimeter of eye recession. Like Malunion, late repair for established anophthalmos is extremely difficult.
Wow. What about double vision? Diplopia.
Also quite common, unfortunately. Reported in maybe 17% up to 83% of cases in some series, particularly common with pure blowout fractures of the orbital floor.
What causes it?
It can be due to several things. Simple swelling initially, or entrapment of the eye muscles or the tissue around them in the fracture line, or direct injury to the nerves that control the eye muscles. While some cases resolve as swelling goes down, persistent diplopia often needs further investigation and possibly surgery.
Any other eye issues? More severe ones?
Yeah, thankfully rarer, but more severe things can happen. Traumatic hyphema, that bleeding inside the eye we mentioned. Traumatic optic neuropathy, damage to the optic nerve causing vision loss. Superior orbital fissure syndrome, a rare but complex set of symptoms from injury to structures passing through a gap at the back of the orbit.
Scary stuff.
And then there's the one that's a true surgical emergency, retrobulbar hemorrhage.
Bleeding behind the eye.
Exactly. Bleeding behind the eyeball, usually post-operatively, but can happen from the injury itself. It builds up pressure rapidly, compresses the optic nerve, and can cause permanent blindness very quickly if not treated immediately.
How is it treated?
Requires immediate lateral canthotomy and cantholysis, basically cutting the outer corner of the eyelid and the tendon there to release the pressure instantly. It's rare, maybe 0.03% post-op, but critical to recognize and act on immediately.
Wow. Okay, one last one you mentioned earlier, trismus. Difficulty opening the jaw.
Right, trismus. That usually happens if the inwardly displaced zygomatic arch or body is physically blocking the movement of the coronoid process, which is a part of the lower jawbone. If reducing the fracture doesn't solve it, sometimes a surgical adjustment might be needed later.
Man, what an incredible journey, really, decoding these zygomatic complex fractures.
It's a lot, isn't it?
Yeah. From understanding the the really intricate design of the cheekbone and its crucial role to seeing how diverse things can cause these injuries, cars in LA, fights in Glasgow,
Mm.
then exploring the precision of modern diagnosis with CT, and the systematic, often really delicate surgical techniques needed for repair.
Yeah, the plates, the mesh, the hidden incisions.
Right through to all those potential complications we just covered. It truly highlights both the incredible vulnerability, I guess, but also the remarkable resilience of the human face.
It really does, and it makes you think, doesn't it? Considering the intricate balance of the human face, what other everyday actions or maybe seemingly minor impacts might have these cascading effects on these delicate structures that we just, we take them for granted most of the time?
That's a great point.
Our faces are just this marvel of engineering, aren't they? Capable of incredible resilience, yet also vulnerable in specific, sometimes surprising ways.
Indeed. It really encourages you to marvel at both the body's resilience and, frankly, the sheer medical ingenuity required to put things back together when they break. Thank you for joining us on this deep dive.